I'm just looking around to see if there's anyone that I know. So I'm one of the medical oncology consultants. I work in a clinic which runs alongside Martin Kaplan's clinic. So we have both of our clinics running alongside by side on a Monday. But I do two things. I'm a consultant medical oncologist, but I also run a research lab working on solely neuroendocrine tumours. This is funded by Cancer Research UK. So research is something I'm very, very passionate about. I've been in my current role for the last 5 years or so. And I thought I'd tell you a little bit about my role, then a little bit about some of the work we do, and just talk about some of the places where we may be moving towards in the future in terms of what we can learn about neuroendocrine tumours. So we're a large centre in the UK, as I'm sure you know, and in 2010 we were awarded European Centre of Excellence, and this was partly based on the patients that we look after. You are the main focus of everything we do. And then around that, we have clinical trials-based research, and also we have basic science and laboratory-based research. And that's where my expertise is, but I also work in clinical trials. But like I say, everything we do is based around you and wanting to make things better and wanting to make outcomes better. We have a large number of referrals that come through every month. We have a big team meeting every Tuesday where we discuss sometimes up to 100 patients or so, and that's every new patient that comes through. Or if we're changing the treatment treatment decisions, we always sit down and discuss that, and then we see you in clinic once we've had those discussions with all of the experts in the room together. We have a large number of patients that we also see regularly for follow-up. And then one of the things that I've set up, which is really important to help the research in terms of learning more about these tumours, is a biobank. And some of you may have been approached over the years to read about either clinical trial research or laboratory research to ask for your consent and your permission to work on some of the samples that you may have had taken during your routine follow-up. And the biobank's very important for us in terms of doing research because it gives us really well annotated, sometimes tissue samples if you've had an operation in the past, and sometimes we take blood samples and what we call plasma and serum. And that's really important for us for the future so we can actually learn more about the preliminary research that's been going on over the last few years. So this is what I do. Monday to Tuesday, I'm in the hospital taking selfies in clinic. On the left. That isn't the only reason why clinic runs late. We are genuinely overwhelmed with the volume and number of patients that come through, so we are working flat out from 8 o'clock in the morning through to 3, 4 o'clock in the afternoon on a Monday. Tuesday we have our team meeting where we discuss all the cases, and then Wednesday to Friday I'm in the research lab, and in the lab I have PhD students and postdocs, and all we work on is neuroendocrine tumours. Over the last few years, we've concentrated mainly on small intestinal and pancreatic nets, and we're now moving into studying lung, so bronchial neuroendocrine tumours. But that's not all we do. We're passionate about making things better, and so I also, in my spare time, we raise money. I raise money for Cancer Research UK and Macmillan. I think Macmillan are a fantastic charity for supporting patients, but Cancer Research UK funds the actual science and the laboratory work. And so some of the things that I've done over the years is have a big passion for open water swimming. So I've swum the English Channel, that's me on the right, 19 hours in the water. I've swum the Gibraltar Strait, I've swum Lake Zurich, I've swum from the British to the US Virgin Islands, and this summer I'm swimming the Hellespont to swim from Europe to Asia. And I've put all of that together, so I'm swimming across continents to raise money for cancer research, because we're absolutely passionate about making outcomes better for all of our patients. So I'm sure all of you are very aware that neuroendocrine tumours on paper can be described as rare, but to you and your families, they're not rare. They're a massive part of your lives. In terms of all of the cancer in the UK, it accounts for less than 1%. And the incidence, so the number of new cases per year in the UK, is about 5 people in 100,000 of the population. The prevalence is the number of people walking around with a neuroendocrine tumour per population. And the prevalence is higher than any other upper GI or liver cancer. And that's because, compared to some other cancers, some people with neuroendocrine tumours can live for many, many, many years. So it's to do with the caseload and the distribution of the patients that we look after. Most commonly, they occur in the GI tract, so either in the intestine or the pancreas, and about a third in the lung. Unfortunately, because some of these tumours take a long time to present, and I'm sure you all have many stories between you about how long it may have taken from when you first didn't feel quite right to actually having the diagnosis, unfortunately, a significant proportion of patients may present when the cancer has already spread, most commonly to the liver. When we think about the neuroendocrine tumours in the bowel and the pancreas, what we mean by heterogeneous is there's different subgroups within this big family. So in medicine, we like to label things to get a feel, and we give something in box A, treatment A, something in box B, treatment B. But they're actually quite different. They're a heterogeneous group of tumours. Some of them secrete these peptides, which can lead to syndromes and other things such as insulinomas and glucagonomas. And when we think about the pancreatic neuroendocrine tumours, they account for just 1 to 2% of all pancreatic cancer. So the most common pancreatic cancer is adenocarcinoma. And you may have been told when you were diagnosed, oh, don't worry, you've got a nicer form of pancreatic cancer. And actually, to you, that doesn't make any difference whatsoever. But just the statistics are that it's 1 to 2% of all pancreatic cancers. What we mean by sporadic is about 90% of cases, there's no firm family history of neuroendocrine tumour, because I study DNA and genetics, and I get asked quite commonly, what's the risk to my daughter, my grandchildren? And 90% of cases, there's no known family history. In terms of pancreatic neuroendocrine tumours, about 10% can be associated with some of these syndromes, so you can actually track the tumours through families when you look at family trees. And here are some of the genes at the bottom that are related to that. So why do we want to study neuroendocrine tumours and understand more about them? Well, the bottom line is it's very difficult with rare cancers to perform large-scale studies and pull out really meaningful answers. And what we have here at the Royal Free, and why I put the application, got the grant funding to do the research, is we're in a unique position to do some really informative large-scale studies. And it's only because of all of you and all of the patients that have agreed to take part in this that we can understand more about where these tumours come from, so that at the very basic level, we want to diagnose and catch them early. But then if they are there and they may have spread, we want to be able to learn more about how these tumours are behaving and improve our treatment options for the future. So that's where we're going. But it's a long road. This kind of work takes years and years and years to understand and unravel the biology of these tumours. We know, this is from a study from America, where they looked back at the incidence of all cancers, which is the blue line, and looked at the incidence, so that's the number of new cases per year, of neuroendocrine tumours in the red line. It's increasing. So this is going back from 1973 over to 2004. There are a number of reasons for this, and again, some of you in the room may have had your tumour diagnosed because you happen to have a scan for something else. And we generally are investigating and scanning people a lot more than we used to. We're also an ageing population, so more people are diagnosed with cancer. So up until this year, you could say there's a 1 in 3 chance of any of us being diagnosed with a cancer in our lifetime. And that includes perhaps early stage skin cancers which can be removed, but that figure has changed. And Cancer Research UK now cite that if you're born after 1960, that's a 1 in 2 chance of being diagnosed with any type of cancer in our lifetime. So it partly reflects that as well. And as I mentioned earlier, the prevalence, the number of people walking around with an endocrine tumour, is higher than any other what we call gastrointestinal cancer. So on the left is liver cancer, esophageal is the tube going down to the stomach, there's a pancreas, and gastric is the stomach. So on the right-hand side, you can see neuroendocrine tumours there. There's a lot more people walking around with this type of tumour than other gastrointestinal tumours, which sometimes might have a higher profile. So I've always been very grateful to Cancer Research UK for acknowledging this tumour type as something that was worth investing in. So we need to learn more about the tumours, because when we sit in our tumour board meeting on a Tuesday, we talk for hours and hours and hours and hours, and we pick each other's brains and we try and work out what the best thing is to do. And from a cancer specialist perspective, I'm in a good position because we have a number of treatment options. So these are just 3 example algorithms of where we might go through in terms of the treatment options which we'll think about. And in that room we have the surgeons, we have the cancer specialists, we have Martin Kaplan's team, the gastroenterologists, we have endocrinologists, we have x-ray doctors, we have pathology doctors, we have nuclear medicine doctors. So anyone that might have anything to do with your treatment is sat in that room. And we work our way through between us agreeing on what we think is the best approach to this. But then we sit down with you and have a 2-way conversation because it's your decision. And we can give you what we think will be a good idea based on our experience, but it boils down to having a conversation and making a decision together. But we need to have better and better defined information to work our way through these complicated treatment algorithms. So I'm going to talk to you a little bit about studying DNA in tumours, which is what I do in the lab. So can anyone tell me what DNA is?
Deoxyribonucleic acid.
Well done, that man. And who said that? I do lecturing as well. And what does it do? What's the purpose of DNA? What does it do?
Catching criminals.
That's true. And
it allows replication of your entire body, effectively, through the base sequence.
yes, so it has a sequence of 4 letters, and in that is a code, and it codes all of our genes, which are then expressed when each of our cells replicates. And essentially when a tumour develops, it's the way that the DNA replicates and the way that the genes are expressed go wrong. And why cancer can be described as an illness of old age to a certain degree is all of your cells are replicating all the time. So there are 3 billion base pairs in our DNA, in our whole thing, 3 billion. And can you imagine, if you're typing that up and replicating it and you're matching it, the number of mistakes that might be made in copying out 3 billion letters every time a cell divides. And that's where errors occur. And as we get older, the errors in this replication can increase. So what we've got here on the left is looking at the nucleus of a cell, and all of the numbers are what we call chromosomes, and that's how our DNA is packaged up. Now, can anyone tell me if this DNA is from a man or a woman? The questions will get easier in a minute. Can you see? The bottom right-hand corner of that white box is the clue.
X chromosome.
How many are there?
1.
Well, it looks like an X, but there's how many side by side?
2.
2. So it's a woman. So there's 2 X chromosomes. Men have 1 X and 1 Y. So this is the DNA from a woman with all the chromosomes painted up. And as I mentioned, there are 3 billion bases. This is the code. In 2001, it was announced that the sequencing of the human genome had been completed, and Tony Blair and Bill Clinton both stood outside their various presidential places saying, yes, we're going to cure all illnesses. It's all going to be fantastic. We've sequenced the human genome. It was a massive effort. And because of all this information is publicly available, scientists like myself, we can access it. So we can get the sequence of any gene we're interested in. And to put that into perspective, my PhD was in bowel cancer. I spent 6 months full time trying to sequence 1 gene. And we have over 20,000, okay? So we have our 3 billion letters making our DNA, and of that, only 1% is actually then related into the genes that do very useful jobs and make our tissues, make hormones, help us grow. So they help regulate everything in the cells. And this is just a little bit about the story of sequencing the human genome. So 10 years after this, there was a big kind of reflection. So in 2011, it's a big reflection of where have we actually gone? What have we learned in terms of managing patients on a day-to-day basis about cancer and other medical problems. And over that 10-year period, we've identified 400 new genes which are related to cancer. And the other thing that has really, really exploded over the last 10, 15 years or so is actually the technology that allows us to sequence. So it took years to sequence the first human. And now I can send a sample off for £500 and I can sequence every coding gene in any one of you in a few days. So that's where we are. And this original project cost hundreds of thousands, or over a million pounds to do. So this was the anniversary follow-up in Nature, and they had pictures of all the people that are involved in this massive, massive international project. And down there, they've blown up 2 people. Who are they? Yeah. This is from 1953. And we've come quite a long way in terms of our understanding of DNA and its function and the way it's structured. And there are many other, apart from having what we call mutations, so changing in the letters, so getting the sequence of the letters right, there are many other ways in which the control of our genes are switched on and off. And that's another thing that I study in the lab. We look at something called methylation. So methylation of these DNA molecules also affects how our genes are switched on and off. And this is just something to give us some idea of what can we learn by looking at the DNA sequence of tumours. And this goes for any tumour. These are some of the things we can actually learn about that tumour. And we're reaching a point now where we can take blood samples and look at DNA that's circulating around the body, that's released from both normal and tumour tissues. That's somewhere where we're moving forward. And then when we think about the technology, I'm not giving too much of my age away, but I was doing my PhD around 2000. And as I said, it would be a massive effort to sequence and work out the letters in these in genes that we might be interested in. Whereas now we have what's called high throughput technology, and something that has really exploded alongside that is the computing infrastructure to manage massive volumes of data. And there are 2 papers that I was particularly interested in. So on the left, some of you may have heard about this, it's been in the press quite recently. But in the left and at UCLH, there's a group that developed a blood test to look at circulating DNA in the mother's blood of the baby. So a pregnant woman, just do a blood test, and within the mother's blood, there's circulating DNA from that baby. So from just a simple blood test from the arm, you can then look for Down syndrome, other inherited disorders, without going and doing amniocentesis and other invasive tests. And something which is great about science is once someone's developed a technique for something, you can then transfer it into other fields. So this is exactly what's being done in cancer medicine now. From a blood test, you can actually then isolate and explore some of the circulating DNA in cancer patients, which reflects what's going on in their tumour. And I'm sure every single one of you's had a biopsy. That's not very pleasant. And what we do know is that over some years, and if we're giving different types of treatment, the tumours can change their spots a bit and behave differently. And so rather than going back and taking a number of different biopsies, where we're moving towards in the future is doing a blood test, and we can then analyse the DNA that's circulating in the body. And then on the right, this entertained me one Sunday morning. So this is Ozzy Osbourne. And what he did, about 5 years ago now, he paid $10,000 to have himself sequenced, his own DNA sequence. So he sent a blood sample off and had it analysed and had the readout. What do you think might be some of the problems or issues that might arise if you just sort of did a blood test, sent it off and had a readout? Well, gene A works, gene B doesn't work very well, gene C looks all right. What do you think might come of that?
A neurotic population.
It would be a neurotic population. I suppose there's 2 things actually. So 1, we're a neurotic population. 2, you really need to be able to interpret this information. So any patients that we might suspect in clinic that have something going on genetically in terms of the family tree or the family history, it's absolutely vital that you have genetic counselling as a family, because you have to think about what might I do with this information. So you can throw up all sorts of things that you may not know about. And here's something that comes up regularly in genetics clinics. 1 in 10 people aren't from the father that they thought they were. Fact. So that's the top problem to iron out. But you might say, oh, there's Ozzy Osbourne, he spent his 10,000 US, what have we learned? You say maybe on the left you've identified the biting heads off bats gene or the worshipping the Dark Lord gene on the right. But in all seriousness, there are a number of subtle changes in terms of our DNA sequence that might confer an increased risk to other types of cancer, but we can't give any firm statistics to back that up. So all I'd say is be very careful about that, because in the States you can actually send off blood to be tested for common bowel cancer and breast cancer genes and things like that, and none of those apply to neuroendocrine tumours, so you know. So one of the things that we do, as I mentioned, so in the middle we have a pointer, but you can see there's our code in the middle. At the bottom there's our gene of interest. So we want to see which genes are switched on and which genes aren't working so well. So generally a cell that becomes cancerous has either got a foot on the accelerator too much, so the cell's turning over too quickly, or you've lost control of your brakes. So there are groups of genes that switch things on, there's groups of genes which switch things off. So we know broadly what these genes are, but we have to look at every level. So this is the methylation, the red lollipops. This is something else that I look at in the lab along with the sequence. And then the copy number is sometimes when cancer cells are replicating quickly, you can have 2 or 3 copies of the same gene because it's all raveled up. The chromosomes can get jumbled up, and so you can have extra copies of genes, which again turn genes on and off. So in order to really understand what's going on, you have to put all of this information together.
Is there a repair mechanism in the body?
Yes, so there are a number of, that's a very good question. So there's a number of what we call DNA repair genes. So every time your cell replicates, it has like a proofreader behind. It's like typing, it has a proofreader behind, and it has various enzymes, these molecules that do very useful things, and they can actually then pull the DNA apart, take the wrong letter out and put the right letter in. So you've got sort of the typist here, typing 3 billion letters, and then behind it you've got this proofreader. And they're different types, and some inherited cancer syndromes, bowel cancer syndromes, are to do with what you call mutations in DNA repair genes. There's a whole group of bowel cancer. So you hit the nail on the head exactly. So there are inherent proofreading, but again with the volume and the number of times that our cells turn over, this can still unfortunately go wrong. So this took 4 or 5 years to get together. So we were the only group in Europe that worked with a large group in America and also in Canada. And we had to look at 180 tumours to identify mutations in this gene. And this gene is one of the genes which turns things off. So with this situation, you've lost your brakes. But what we have learned about the intestinal neuroendocrine tumours is they just don't have very many mutations. So people with lung cancer and with melanoma and skin cancer have lots and lots and lots and lots and lots and lots of mutations in their tumours. Does anyone know why that might be? Think about why do people get lung cancer broadly and melanoma? Smoking and UV. Both so smoking and UV just damage your DNA as well. So the UV exposure can damage the DNA in the skin, and smoking with the sort of nasty toxic carcinogens, that damages your DNA. So the background mutation rate in those 2 types of cancer is really high. And what we saw in the neuroendocrine tumours is they are low, 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 virtually lower than any other solid tumour. And so the background rate was very low, and then only 8% of cases we found this mutation. But what I've subsequently found is it's the methylation, those red lollipops, which are really disrupted. So it's quite a unique type of tumour. And it may reflect that in some cases they can take a very long time to come and to grow bigger. So that's some of the work that we've been doing on tissue. And in order to get really interesting and useful results, we have to now work internationally. So I work with a number of groups in Europe, I'm known in the States, and you have to get out there because in order to do something worthwhile, you have to study things in big numbers. And we continue with our collaborations now, looking at the methylation, but also we're now looking at bronchial. So we're looking at the lung tumours. We looked at the pancreas, we've looked at the intestinal, we're now moving to the lung. So I'm just going to talk for the next 5-10 minutes about something else that was developed in our unit. It was by my colleague Tim Mayer who identified and validated what we call circulating tumour cells in this type of tumour. So as I mentioned, there's DNA from tumours which might go around our circulation. In some patients, we've identified tumour cells which can be isolated and identified, again, just from a blood sample. So like one of your regular blood test tubes. And what we can then learn from that is we can learn about the biology of those cells, because the ones in the circulation are thought to be the ones which have actually popped off and left the original, what we call the primary tumour, and maybe going somewhere else, either to nestle in a lymph node or to the liver. So some of you may have known that when they did the original operation, some of your lymph nodes were involved, or you may have had some disease in your liver, and that's to do with the tumour cell leaving what we call the primary, the original tumour, it gets itself into the circulation, travels around and gets itself out again. But by studying these circulating cells, we can learn about what actually drives these tumours to spread, with the aim of stopping it before it gets to that point. So those are the sorts of things we can learn from this type of work. Generally, when I was talking about sequencing the DNA, we carefully extract what looks like tissue and tumour under the microscope, but that has billions of cells. But what we're doing here is looking at the DNA from one single cell and learning about that. So what we do is we can take a whole blood, like your regular blood sample. We use a special machine which puts fluorescent tags on, which identifies the tumour cell in the blood and excludes it when you compare all of what we call our red blood cells, which carry oxygen around, white blood cells, which if any of you've had chemotherapy, you know that we're absolutely focused on, and they fight infection. And you isolate these tumour cells, and then we can then put them into another machine, and we get a single cell in every tube. And that's a tiny, tiny, tiny thing with a tiny amount of picograms of DNA. And again, this just shows you some of the technology we use, but we get a single cell into these different cages. We have nearly 80,000 cages. We use tiny volumes, and then you can see on the bottom picture there's a little round white blob in the grid, and that's an individual cell in one of those cages. And like I say, we use different fluorescent tags to tell us that this is definitely a tumour cell in relation to an endocrine tumour. And then the next step that we've done is we extract the DNA from a single cell, and then we amplify it so that we can actually then sequence it to learn more about how those genes are switched on and off. We then amplify it, and then on the top right there, that's what some DNA sequencing looks like, and that's a particular gene called KRAS. So we can then learn about the sequence of the DNA in those cells. So as I mentioned earlier, from this we can understand more about how the tumour spreads, and we're not just doing this because, oh, it's a fascinating thing to do and it's lovely bits of equipment and look at those nice fluorescent tags. It's because we want to learn more about how this type of tumour evolves, and if we can catch it before it spreads, and ideally catch it before it even starts in the first place, we'll all be in a much better place. We can look at circulating tumour cells to see how the tumour might change its spots through treatment. As I mentioned, some of our patients might have chemotherapy or other sunitinib or everolimus molecularly targeted therapies, and the tumour can evolve. It's a bit like a bacteria becoming resistant to antibiotics, something conceptually a lot of us are kind of familiar with. And tumours can do the same if you're having treatment. So if we can use this to then learn more about those tumours again. And it can also help us in the future choose our therapy more appropriately, and then learn why that treatment may have stopped working. And again, it's all to do with tumours sometimes changing their spots to evade detection. And then in the future, we'll be using a circulating free DNA that I talked about again from a blood sample. So what I'm hoping for and what we're working towards is turning this sort of complicated algorithm that we spend hours discussing in a very productive way each week into something that's far more streamlined. So at the moment, we're on the left-hand side. We want to learn as much as we can about these tumours. And then through that, we hope we can then give our patients more accurate information about what this all means and what might lie in the future. And then if unfortunately things do change and we need to change the treatment or the tack of the treatment, we can then do more tests, but we imagine in the future these will be blood tests looking for tumour cells or DNA to help guide us as to what we do next. So that's where we're moving. This isn't something that's unique to neuroendocrine tumours, it's something that's being introduced across lung cancer and melanoma and renal cancer. Those are the sort of three cancers where this is all progressing apace at the moment. So what we've learned from the tissue is we've identified in the pancreatic and the intestinal tumours so far, and we're moving into the lung tumours. We're learning about what makes these tumours tick. And something that Liz is going to talk about, we learnt that in the pancreatic neuroendocrine tumours, there are two pathways called the VEGF pathway and the mTOR pathway, all these genes which switch on and off. And now we have two drugs which target those. So we're learning more about the biology of the tumours. We have identified and we are using circulating tumour cells, but still on a trial basis. This isn't something that we do routinely, patients coming through clinic. We're at the stage where they're now included in some of the clinical trials that we have ongoing, because you always have to validate something new before you roll it out across a whole population. And as I mentioned, in the future, we'll be moving from the circulating tumour cells into looking at DNA that's circulating. So with that, I'd like to thank you all. And I'd like to thank all of the patients all over the UK and further afield who've agreed to take part in the research, because without the patients we would have nothing, absolutely nothing. We have the biobank up here at the Royal Free. I continue to go swimming in various places, and I'll and we will obviously keep you updated. So we do have some where's Jorge? We do have some updates on the website here, but also the Net Patient Foundation has research updates as well. I'm sure many of you are familiar with that website. So yes, but do get in touch. So thank you very much.
Thank you so much, Chrissie. And now is the time for questions and answers. So if you have some questions or things that you want clarification.
Could you tell us again what cfDNA actually stands for?
Circulating free DNA. So yeah, and all of us have DNA that goes around the body, because our normal cells, when they come to the end of their lives, are broken down, and there's various mechanisms that then releases that DNA, and then it all sort of gets broken down and got rid of. So in all of our circulation, we all have DNA, but in cancer patients there's circulating free, and sometimes it's called ctDNA, because that's circulating tumour DNA. So there's sort of different annotations for that.
I was quite interested that about 10% of the neuroendocrine tumours are inherited, which means that 90% are not inherited. Now, to complete layman, there seems to be a big distinction between these two, because the inherited ones come from within your own body and from previous generations of your family, whereas the other 90% presumably come from completely outside factors. And I just wonder why or what the link is between those two different types of catching the disease.
So what we understand at the moment, so that the 10% are related to different types of pancreatic neuroendocrine tumours. So there's the MEN syndromes, neurofibromatosis, and also von Hippel-Lindau. So those are syndromes where those individual genes are mutated. So the sequence is mutated, then that's passed either in the egg or the sperm from father to daughter or son. But what we know across many other types of cancer is there are far more subtle changes which may have been inherited, which then makes you have a higher predisposition. But we don't know what those are at the moment. So the 90% of what we call sporadic, and when we're sat in clinic, it's you have just been unlucky. You have done nothing wrong, you've been unlucky. And that doesn't really help. It doesn't really help. And we have this conversation regularly, particularly when you're thinking about your loved ones or your children or your grandchildren. But it's the pancreatic neuroendocrine tumours and a subset of bronchial, because some of the lung tumours can be related to the MEN syndrome, MEN1. There's only recently, a month ago, been one paper that's identified a couple of families on the intestinal side. So there's no such syndromes as there are on the intestinal tumours, it's just the pancreatic. And as I said, when we looked at the tumours down the microscope, there are very few mutations. So there isn't anything that we can say in terms of, well, you must have done this or you must have done that. You haven't. No one's done anything wrong. You've been unlucky. And as I say, that doesn't often help very much when you're trying to work through all of this when there's a lot of information coming through.
Is this bad luck evenly spread around the world, or are there regional variations?
That's a very interesting question, because we have subtle differences in our 3 billion base pairs. We have these little subtle changes which are distinct to different populations. So different types of cancer can have a high what we call incidence in different countries, but often a lot of that is to do with other factors. So in Japan, there can be more gastric cancer. In certain parts of the world where you can have cancers that are related to having virus infections or hepatitis viruses, there's different types of cancer in that respect. And then there are certain subpopulations. So the Ashkenazi Jewish population, they have a higher incidence of different types of breast and bowel cancer, for example. So your heritage and that genetic makeup can change a predisposition, but there are no known groups really within sort of neuroendocrine tumours that fall into that category specifically.
So there isn't somewhere that's never had it?
No.
Is there any connection with, as far as I know, in my family, nobody's ever had an X-cancer but me. But the male side of our family, there are several people that have got different types of ordinary cancer. I know you shouldn't say ordinary, but I suppose it is. Is there any connection with that?
No, there's no association in that sense. What we do see, and again this may have happened to some of you in the room, is that when you have your normal bowel cancer, about 10% of bowel cancer patients, if they have an operation, we find a neuroendocrine tumour there. That's rare, so about 10%. In terms of families having different types of normal other solid tumours, there's a familial syndrome, but I'm not saying that's what's in your family at all, because it's really obvious. So there's a gene called P53, it's very, very important, and if you lose that, families can get all sorts of different types of cancers, because this is such an important gene in terms of putting the brakes on cells. And that absolutely isn't what's going on in your family, but there's no association between those and sort of neuroendocrine tumours.
That's interesting, thank you.
Going back to the gentleman's question there about racial differences, could that be a consequence of diet?
There's no, in terms of, the short answer is yes. In terms of gastric cancer in the Japanese population and lots of raw fish, yes, or exposure to certain things. In terms of neuroendocrine tumours, there's nothing that's been pulled out or identified that we know of at the moment in terms of a dietary risk factor. Yeah.
Could I just ask, in my particular case, it was very late before anything was noticed. I mean, when I say very, I mean very. And I'm just wondering what's being done about finding them out earlier. It does seem to me you can go and have a complete medical test, blood test, liver, everything. It still doesn't pick up. Yet you might have a reasonably advanced neuroendocrine tumour.
So there are two factors, and I know it's incredibly difficult for any of you that have been feeling not quite right, been going to the GP for some time and feel like nothing has really been followed up in the right way to try and pin down what's going on. But a lot of these tumours take many, many, many years before there's even anything you can see and measure on a scan. By the time you have something that measures 1 centimetre on a scan, there's 1 billion tumour cells there. And anything under a centimetre, we can't actually say definitely yes or no whether that's a tumour or not. So putting that together with what we see in men, but often in women with the intestinal tumours, is they may have been told they have irritable bowel syndrome because they've been having these non-specific bowel symptoms for years and years and years and years and been treated for irritable bowel. It's only when something quite significant happens that the diagnosis is made. And so Martin Kaplan, many years ago, about 15 years ago, set up a campaign about the quiet cancer. Because we know, and there's studies internationally, it's not just the UK, this isn't a reflection on the USA, on the NHS or GP referral patterns. There's often a 5-year delay from when someone thinks, I'm just not quite right, to having the firm diagnosis. And what we want and hope and aim to do is to bring that much further forward. We do find that people are scanned a lot sooner and more frequently for other things, but it's very hard, and it's also easy for me because when I see you, pretty much all the tests have been done, the diagnosis has been made, and I see neuroendocrine tumours all day, every day in clinic. It's all I do. Whereas a GP will see 1, maybe 2 cases in their whole career. And so I absolutely understand the frustration, the difficulty when it's taken a long time to get there. But we're always very polite to the GPs to try and actually guide. If there is something that could have been flagged to help them in the future, we always feed that back.
I think my question is more along the lines of nobody, well, in my case, I didn't even feel ill. So, by the time actually the GP picked it up jolly quickly, but it was I who didn't go to the GP. So, I'm just wondering whether there's, I don't know whether, you know, a simple urine test can pick up something like chromogranin A or something, and you can look at that and say, well, that's too high. He should have some more tests, or something like that. I'm just throwing it out.
So one of the aims of the research is to look for what we call biomarkers. The problem with chromogranin A is it's very, very non-specific. Many, many, many things can make it raised, including different tablets you're on. So it isn't a specific enough test for us to use as a public health screening test. So there are various different factors we have to sort of take into play with that. Yeah. And I suppose the other point I was going to make is depending on where the primary site of the tumour is, the same with normal pancreatic cancer, because it's tucked away right at the back of your abdomen, your tummy, you don't know anything's going on. It's the same with the normal pancreatic cancer. The tumour may well have spread before you're diagnosed. It's the same as women with ovarian cancer, because it's the ovary small, it's tucked way down in the pelvis, don't know till things are really quite big that you notice something is going on. So unfortunately, there are subtypes of tumour where things really have to have grown quite a lot before you may even notice or develop any pain.
We're having blood tests taken every fortnight. Are those samples going through your analysis on the DNA, or is this for something else?
So if we're taking research samples, then...
well, we don't know if they're research or not.
So the short answer is we wouldn't do it unless you'd given your permission and signed a consent form. So we approach patients when I'm saying that we've just been finishing off a whole big group of research, so we haven't consented a whole bunch of new patients for a little while. But what we do is you'll have some written information about the study, you'll have time to read about it, see if you want to be involved, and then you sign a consent form in the same way you would for a clinical trial. So we don't ever routinely send any of your samples off for anything to do with research without your permission.
But are the research results, when you're examining the samples, are they fed back to the patient?
No.
They're not?
No.
It's just a pure research process?
At this stage,
okay.
Because you have to then validate the finding, particularly with circulating free DNA. We're very, very, very early stages with that. Yeah.
When do you see it going?
So the tissue-based work we've just had published, so we have 2 papers published on pancreatic and the intestinal work. The circulating tumour cell work has been published by Tim Mayo, and all in sort of big cancer journals. And then the circulating free DNA, that's a work in progress. So, and it will be a good few years before that that moves forward. It's just the way that you have to, once you've identified things, you have to validate them and look in other groups of patients. So it's a big project.
Yeah, going back to the misdiagnosis or inability to diagnose. I mean, I was treated for IBS for 9 years, over 9 years, and I kept going to my GP and saying, well, I've got friends who've got IBS, but they don't suffer in the way that I suffer. They don't roll around supermarkets in pain and so on and so forth. And I just find it strange that my GP said to me, I'm aware that hot flushing, which I'd suffered with all those years, is a pointer to an endocrine tumour, and yet at no stage did anybody try to determine whether my problem was a neuroendocrine tumour or whether it was IBS. And I just find what concerns me is the fact that it's just kind of accepted. We got it wrong, box on. But it's happening too regularly, and there should be some kind of I've spoken to so many people now, so they treated me for IBS. There must be some guidelines that GPs should be required to sort of, just think about. If somebody's coming in repeatedly saying, can you take my blood pressure because I keep burning up, I'm flushing all the time. And yet, that's not even recorded in your notes. And it just worries me, this kind of, IBS, that'll do, put that down. And that's the thing that worries me.
So I suppose the first thing I can't comment on at all is your GP and the consultations you may have had. And we don't think it's acceptable for people to have spent years and years trying to work towards a diagnosis. It's something we're working very hard to change. And we do engage, we have educational forums with GPs, as I say, because most of them see 1 or 2 cases in their career. And then most recently, there's been a big effort across all types of cancer, because I'm sure you're aware, and in the press, unfortunately, we fall behind many other countries within Europe and further afield in terms of picking up the diagnosis and getting treated quickly. So only this week and the week before in the British Medical Journal, there's now new algorithms. You may have heard of the 2-week wait for anyone that a GP suspects might have a cancer. They have to be seen and at least start that investigation sort of journey within 2 weeks. There's now new guidelines covering any type of symptom that a patient might walk into GP surgery with. And I absolutely understand how frustrating it has been for any of you that's had a long journey in getting to the diagnosis. But there are efforts being made to improve and streamline this, and particularly, as I say, across all types of cancer. So there are red flags for GPs now. There's new algorithms where, if Mrs. Jones has had a cough for more than 3 weeks, flag, do a chest X-ray. So and that has been there for a while, and since the 2-week wait has come in, that has improved and streamlined things a bit. But we are all making as much effort as we can to improve that, because it's not something that we would ever sit back and say that's a good situation to be in.
Yeah, I just wanted to say that I share the commentary about symptoms, because unless the patient or potential patient knows that there are symptoms, because I hadn't got a clue. I used to get pains that gripped me like I was in a constricting corset. And they went away, so you didn't worry about it. But I just wanted to make a statement. From a research scientist point of view, how do you look at the human body as such a wonderful place that it ever got to be this complicated, and how it just ticks from day one?
It's what makes me get up in the morning. It's what takes me to work. But what's the 2 different things I do are very, very different. And what I really enjoy is looking after the people. And a lot of the treatment we give, for all the right reasons, we're following protocols for safety reasons. We're not prescribing chemotherapy. What makes that interesting to me is the person and their family and the people sat in front of me. And I really enjoy that. In the lab, I feel like my brain is breathing and being creative, because you can have an idea and follow it through. And all of those questions like, wow, what genes have made this thing happen, this and I have scientists that don't look after patients at all. So you're putting these brains together so they can come at things from a completely different perspective. And it's interesting because it's the doctors that often say, well, that's all very interesting, but there isn't a drug that you can use for that. So come on, let's get back on, let's focus on what we can actually do. So you have to have these teams, and we have what we call bioinformaticians, and these are people who look at this massive volume of data. So I have sort of two different hats, but I love both hats for different reasons. And that's, But it's always about always looking for better. I mean, why I became a cancer doctor in the first place was because cancer doctors will never say, that's breast cancer done, let's sit back. You're always looking for better. We will always continue to do that. Okay.
One question here.
Yeah, and I think, yeah.
Chrissie, I think is this working?
I think that is more so that you're recorded for the camera. Yeah.
I think the work you do is amazing, fantastic. Don't go swimming in any shark-infested waters when you're... all right. The prevalence figures I found fascinating, and I might have my understanding wrong, but I think the prevalence is possibly higher, speaking to my oncologist. For example, the recording of nets is not what it should be in hospitals generally, apparently, so it might someone's cancer might be recorded as a colon, a cancer of the colon or the bowel, but actually it was a net. So that's a sort of concern when you actually look at the numbers. But is it true that private hospitals, if you're diagnosed in a private hospital, that doesn't get added to the national figures either? I mean, the national figures are worryingly perhaps a little bit light.
To be perfectly honest, I don't work in the private sector, so I don't know exactly what happens in that situation. What is logged, so our pathologists, so the doctors that look at tissue under a microscope, every single illness and tumour or non-tumour diagnosis a pathologist makes has an exact code, and that code is logged. And there are efforts, I agree, there are cases that may not have been logged accurately. For example, it might have been someone with a normal bowel cancer that had a neuroendocrine tumour found in their specimen, and whether both of those are logged, I don't know. So there are obviously areas for improvement, but in what happens now is when that pathological code has been given to that type of tumour, that's logged. But what I don't know, and they use the same codes in the private sector, so I imagine they are logged. I can't answer that for sure because I just don't know yet.
We could continue for hours and hours, but let's have one more question and we will move on. Thank you.
What does chromogranin B tell you, and what would it tell you if it went very high and then the trend was for it to reduce?
So chromogranin A and chromogranin B are just slightly different molecules from the similar family. They're produced and released into the circulation. And as with there are things called tumour markers, circulating markers. So in bowel cancer, there's one called CEA. In prostate cancer, there's PSA. And chromogranin A and chromogranin B are markers that we use. Not all of our patients will have an elevated chromogranin A. Some of them will have a raised chromogranin B instead. And what we do at the beginning when we're learning about you is we'll look across a lot of the markers, and then when we find the ones that are informative to you as an individual, we can then focus on those. There are certain subtypes of neuroendocrine tumour that more of them will secrete and spit out chromogranin B than A, but essentially we just use it as a marker to track how things are going on. But with anyone that we see, it's actually the person coming through the door. You tell us you're not right before we do any fancy test. I'd say 90% of the time. And then we look at the blood tests and then we look at the scans, but the person in the middle that sat in front of you gives you the most useful information. So we just use it as a marker really, and we can then track it over time. Right.
Thank you so much, Chrissie, for your comprehensive